Hi, everyone. Thank you for joining us today. My name is Courtney Denton, and I'm a project manager at the Texas Epidemic Public Health Institute, or TEPHI. Welcome to our grand rounds for July, and I hope everyone in the Houston area is recovering from the recent hurricane. Today, we have a session lined up to discuss the latest updates and new vaccines that have a global impact. So who is TEPHI? For those joining us for the first time, we're a state agency housed within UT Health Houston. Our goal is to keep Texans safe and the economy strong by enhancing the capacity and resilience of Texas communities to respond to future infectious disease outbreaks. Collaboration is key to our success. We work with a wide range of partners, including governmental agencies, regional and statewide organizations, professional associations, businesses, academic institutions, and community organizations. These partnerships are crucial for achieving our goals and strengthening public health in Texas. One of our featured programs is the Pandemic Preparedness and Response Certificate. This is a fully online, free for Texas residents, 4-course certificate program. If you prefer, you can also have the option to take individual courses without completing the entire certificate. The program builds up to a public health emergency preparedness and response course, which has a tabletop embedded in it, and you can earn CE credits across various public health disciplines. If you're interested in connecting with TEPHI, here are some ways to get involved. You can subscribe to our TEPHI newsletter for updates on resources and opportunities. You can also opt in at that subscription for our weekly Lit Rep, where we curate the latest literature on pandemic preparedness to keep you informed about emerging trends. You can visit our website for a wealth of resources, including videos from our TEPHI Talks, Grand Rounds, Texas Public Health Summit, as well as training courses and communication materials on pandemic preparedness. We offer 1 to 3 hour online courses on topics related to pandemic preparedness that are free for Texas residents. This includes our newly released course on financial management during pandemics. And you can also sign up to be notified about our grand rounds every other month, where we focus on critical topics in infectious diseases. We're excited to introduce our new resource pages on avian flu and dengue. These pages provide current updates, outlooks, resources, and explanations to keep you informed about the latest developments. Just a few housekeeping notes. You can click on the live transcript button for closed captioning. You can use the Zoom Q&A to ask questions, which we'll take at the end of the session. The webinar is being recorded, and since you registered, you'll receive a link to the recording, and it will also be on the TEPHI website in about a week. You will receive a survey here. You will receive a survey, and if you could fill it out, it helps us take note about what's important for people with these grand rounds. And speaking of topics of interest, our next grand rounds will be in September, and we're looking for suggestions for topics or speakers that would be of interest to you. So feel free to drop those ideas in the chat box on the survey, or you can email us. And so our speaker today is Dr. Catherine Teresi, an infectious disease epidemiologist and professor at UT Health Houston School of Public Health. Dr. Teresi plays a major leadership role in TEPHI. She previously practiced public health as assistant director at the Houston Health Department, where she served as incident commander for Katrina and H1N1 pandemic responses. She holds a PhD in epidemiology from the University of Michigan and completed the National Public Health Leadership Training. Dr. Teresi was elected to the APHA Executive Board and is currently a member of the APHA Science Board and Joint Policy Committees, as well as a board member of the International Network of Epidemiology and Policy and many local and state public health advisory boards. She is co-editor of the Control of Communicable Diseases Manual and recipient of the 2018 ASPPH Academic Public Health Practice Excellence Award. Dr. Teresi has given 550 media interviews since 2020. So welcome, Dr. Teresi, and I'll stop sharing so you can.
All right, thank you, Courtney. All right, good afternoon, and I want to echo Courtney's wishes that those of you in the Houston area are Doing okay. It's been a rough week. And speaking of that, the dengue website that we shared, that it will not be live until next week. We had planned to have it live for today, but things interfered, like lack of internet. So, welcome. Today we're going to talk about vaccines. Uh, the CDC declared vaccines one of the top 10 achievements of the 20th century in public health. We have eradicated one disease, smallpox. We are working on, although I've had some setbacks, on eliminating two others, polio and measles. We've actually eradicated a disease in animals, rinderpest in cattle. In the United States, there are 31 diseases we can protect against with vaccines, 21 vaccines against 21 diseases are routine in the United States, but we still need new vaccines, more efficient vaccines, updated vaccines. So today we are going to cover some of these vaccines. We're going to cover a vaccine that could be quickly produced if needed, one special vaccine, some vaccines that are under development, a wish list of vaccines, some new vaccine platforms, and then discuss, are vaccines enough to decrease vaccine preventable diseases? That's a lot of topics in an hour. So this is going to be like speed dating, I would call it, with these vaccines. But because I'm not sure who's watching this webinar and what your background is, I want to give you a 30-second immunology lesson on acquired immunity. That is immunity you develop during your life, not your skin, for example, which also provides immunity against infections as a barrier. So we have active immunity, and that's what you develop after you're exposed to an infection or a vaccine, which mimics an infection. And so your body will recognize the pathogen should it come in contact with it. And passive immunity, which you get from something else, either from your mother about the first 6 months of life or from an injection of antibodies. Today, we are going to talk about artificial, and this is antibodies that are made to protect you after getting a vaccination. I also want to say we talk about vaccines for cancer, vaccines against some other things. I'm only talking today about vaccines against infectious diseases. So again, part of your 30-second immunology lesson today. What is a vaccine? So it's a simple, safe, effective way of protecting you against a pathogen, a virus, a parasite, a bacteria. Before you come in contact with it, I would say, fools your body into thinking it's seeing the pathogen. Your body makes antibodies, and you're all primed in case you do come in contact with the real infectious pathogen. Whoops. All right. So vaccines in the last 50 years have been responsible for about a 40% of the worldwide decline in infant mortality. And estimates are, this is from a recent paper in Lancet, I believe, estimates are that vaccines in the last 50 years have saved 154 million lives. 95% of those lives were in children under the age of 5. And also a large number of those lives saved, children's lives saved, were in infants. Vaccines are responsible, again, in the last 50 years for 9 billion additional years of life. Pretty amazing. So we've seen a lot of great success with vaccines, but again, room for improvement. So let's talk first about new and updated vaccines. Last year, we saw a new COVID-19 vaccine introduced. This was using a new platform. The Novavax vaccine does not use mRNA like the Pfizer and Moderna vaccines, COVID vaccines. Instead, it's a protein vaccine, and it seems to work very well. It's a 2-dose vaccine recommended or licensed for children 12 years and then older, all the way up to 105, whatever. So this is a new platform, another choice for people who may not want to have an mRNA vaccine or just more vaccine out there against COVID. Last fall, because the COVID virus keeps changing, we saw an updated, we used to call them boosters. Now we're like with flu, we're not calling them a booster. It's just a yearly update to the vaccine. The one that was introduced last fall, it was both of the mRNA vaccines, so the Pfizer and the Moderna. This targeted the XBB 1.5 variant. It was recommended for ages 6 months and older, and it did provide some protection against the circulating strains because by the time the vaccine came out, XBB 1.5 wasn't the dominant strain anymore. In February of this year, an additional booster of this 2023-24 vaccine was recommended for adults 65 and older. Unfortunately, uptake has not been great as of May of this year, which was the last date that we have data for. Only 22.5% of those eligible, that would be 6 months and older, had this updated vaccine. A little bit better for ages 65 and older, but these are the people who are at higher risk of serious illness and dying. So because the COVID virus has changed during the last year, continues to change, there will be an updated vaccine this fall, the 2024-25 vaccine. This, the FDA and ACIP, CDC's ACIP, is recommending to use a JN1 lineage, and if possible, the KP.2 variant. Now, right now, since these recommendations were made, we're actually seeing KP3 variant as the most. It's now about over a third of cases of, well, variants that we see out there. And so it's what these vaccines will target is not what will be circulating. However, is still expected to provide protection because they're all Omicron. You know, if you go back enough in their genealogy, they are based on Omicron and JN1. So there will be 3 vaccines available this fall, probably some of them in August, some of them in September. Moderna and Novavax will use the JN1, Pfizer will use the KP2. It has already been recommended, although technically that doesn't happen until the vaccine is released, but it will be recommended for those over 6 months and over. And the expectation is that, like flu, each fall there will be an updated vaccine depending on what is circulating. On the horizon, and we'll talk about this a little bit more in a bit, but our intranasal vaccines against COVID-19, and then also a combined flu COVID vaccine. Okay, moving on to our next respiratory virus, respiratory syncytial virus, RSV. There is a new vaccine for older adults. We see 60 to 160,000 hospitalizations in older folks in the US each year, and 6 to 10,000 deaths, again, among people 65 and older. This new vaccine is single dose, and last year it was recommended for those 60 and older using shared decision making. That means talking to your health provider and talking about, is it right for you? Well, the ACIP met in June, so a month ago, and has revised those recommendations. This RSV vaccine is now recommended for everyone 75 and older, and those 60 to 74 it's recommended they get the vaccine if they are at increased risk of certain conditions. There are 3 options of this vaccine. GSK has a recombinant vaccine. There's the Arexvy, the brand name. Pfizer has a recombinant vaccine, and then Moderna has an mRNA vaccine that called mRESVIA. These vaccines, they all are relatively the same in terms of how good they are. They have shown moderate to high efficacy in preventing RSV, lower respiratory tract infection. And they also have been modestly effective in the second season. So you get it 1 year, the next RSV season, winters, it still is pretty effective. Now we also, with RSV, it doesn't just affect adults and particularly older adults, but also babies. Most babies get it in their first year of life. 2 to 3% are infected are hospitalized. Of those who are hospitalized and in the ICU, these are not babies who are at high risk. Over 80% of them were full term and had no underlying conditions. So even healthy newborns can have very adverse effects from an infection with RSV. We see 58 to 80,000 hospitalizations in children under the age of 5 years, 100 to 300 deaths, again, each year in children under age 5. So another group we really want to protect against this virus. For babies, we've got two options. The first is to vaccinate pregnant women late in their pregnancy so that the antibodies they make, remember we talked about passive immunity, those antibodies circulate, get through the placenta, are passed to the baby, and they're protected for about 6 months, which is the time when they're particularly at high risk of adverse infection should they get infected with RSV. So this vaccinating pregnant women has shown to be 82% efficacious against severe disease for 3 months. Again, getting the baby out of that period where they're really at high risk, and 70% or so through 6 months. Again, so this works very well in protecting newborns from RSV. And in fact, that's the CDC's choice out of the two. However, there is a second choice, and a CDC says, if you can, vaccinate the mom while she's pregnant. If not, option 2, I'll discuss, but just do one of the two, protect those babies. The second choice is also passive immunity. So you're not giving the baby vaccine, you're giving them monoclonal antibodies that again last about 6 months, and then your body destroys them. There are recommendations for all infants should get it if the mom hasn't been vaccinated during their first RSV season. If they're high risk, then they should get another dose in their second RSV season. However, there has been a shortage of these monoclonal antibodies, and so CDC is saying that pediatricians need to prioritize giving these monoclonal antibodies to babies less than 6 months and those with underlying conditions. It has also been shown to be very effective at preventing severe illness and deaths in these young infants. Even if they do get sick, it is preventing hospitalizations and ICU admission. Because of this shortage, however, of monoclonal antibodies, there is concern about equitable distribution of them. And are they going to the infants who are highest risk, or are they going to babies whose parents are maybe of higher socioeconomic status? There is also concern that uptake of vaccines during pregnancy is not where it should be anyways, so that increasing awareness of these options is really important for parents. All right, moving on from respiratory infections, let's talk about dengue. Dengue is a mosquito-borne virus. It's also known as breakbone fever because it causes a very high fever. And I had a graduate student once who got it in Guatemala. He said it was terrible, and you really do feel like your bones are going to break. About half of the world lives in areas with high risk of dengue. You can see sub-Saharan Africa there. and Brazil. There's a big outbreak in Brazil right now. And a public health emergency was declared in part of the United States in Puerto Rico in March of this year. Yearly, about 400 million infected, 100 million become ill, and 40,000 people die. We've wanted a vaccine against dengue for a long time, but the virus itself complicates making a vaccine in that there are 4 serotypes, and there's something called antibody-dependent cytotoxicity with dengue, in that if you get infected with type 1, for example, then you get infected with type 2, because you can be infected 4 times, serotypes 1, 2, 3, 4. You are likely to be much sicker. So this is a concern with vaccine development. This is a map of the United States showing where we do see dengue cases. Now, with the exception of Florida, most 99% say of these cases are from travelers who are coming to the United States from an area. They picked up dengue someplace else in the world, now have come to the continental United States. Florida rather, has recently, just in the last month, however, seen 2 local transmission cases of dengue, which indicates that there are infected mosquitoes there. With climate change, we are going to see dengue in other parts of the country as warming happens. So, vaccines against dengue. There is one called Dengvaxia. This is live attenuated. What that means is it's actually the virus itself. There's a big debate whether viruses are alive or not, but we'll call them alive for this. So it's a live virus, but it's attenuated, weakened, so that it can't cause disease. But your immune system doesn't know that. It makes antibodies against it. And so when you if you should see the dengue virus, if you're bit by an infected mosquito, your body says, hey, I recognize that virus, quickly acts to eliminate it. This vaccine has all 4 serotypes. It requires 2 doses. It has been approved in the United States, first dengue vaccine approved in the United States, but for a very specific group of people, children 9 to 16 years old who have had dengue and are living in a dengue endemic area. And I have a list of those territories and freely associated states. If anybody wants to know, you can email me, I'll send it to you. It is not approved for travelers. So if you are going to a part of the world that has sustained dengue transmission, you can't get it. It has worked pretty well, 80% efficacy against symptomatic confirmed dengue hospitalization or severe dengue. Protection lasts over 6 years, which is great. And there was a study ending last year with just 1 dose. If you remember, this required 2 doses. It's always easier to just give 1 dose and not have to get the child back for a second dose. However, bad news is that Sanofi, the producer of this vaccine, recently discontinued it in the United States because of low demand. Now, remember that at the end of this talk, when we're going to talk about some of the reasons why just having the vaccines isn't enough. There is another vaccine called Denvax. It also covers all 4 serotypes. It's also an attenuated, that is weakened vaccine, also 2 dose, looks very efficacious. This vaccine, unlike Dengvaxia, can be given to seronegative individuals. That is people who haven't been infected before. Works well. They didn't see any adverse effects after vaccine administration in people who got it during the trials, and it's currently being used in Brazil. It had been submitted, the manufacturers had submitted it to the FDA for approval in the United States, but seeing what happened with Dengvaxia and the low demand, they have withdrawn that request. And then there's a third dengue vaccine. This also is tetravalent, so all 4 serotypes. It doesn't have a fancy name yet. It's just TV003 and 005. If you have had a previous infection, you can still use it. It has a good safety profile, works pretty well after seropositivity. That means 83% of people who got it made antibodies against serotype 2, 74% against serotype 1 after just one dose. These are undergoing trials right now in Taiwan and Brazil. It's an NIH vaccine, so it is possible that this eventually will be licensed in the United States, but we'll see. Moving on to another vaccine, another mosquito-borne vaccine. We have a second vaccine against malaria caused by P. falciparum. So we have a vaccine, but there has been a shortage of it. And there's a high demand for this vaccine because of such a high burden of disease in Africa. 500,000 children die annually from malaria. So there was, as I said, there was another vaccine. It's called RTS, S. But that vaccine supply was limited. So this new vaccine, which seems to be just as good as the first one, should increase the number of children who can be vaccinated. This vaccine has been shown to be cost effective. It has a long shelf life, which is good, and it does not require sub-zero storage, which, as you can imagine, is a big plus in hot climates like Africa. It reduces symptomatic cases by 2/3 for a year after 3 doses, or even higher if you give it before the malaria transmission season. A 4th dose is recommended just to keep those antibodies level up. Protection lasts for at least 2 years, and WHO has made the recommendation that every child under 2 years old in sub-Saharan Africa get vaccinated with one of the 2 vaccines. It's not recommending one over the other. All right, on to a bacterial infection. Meningococcal disease and meningitis causes meningitis. You may have guessed from the name. And this affects brain, spinal cord, and bloodstream. It's a scary disease because it can be deadly in hours. A child can be fine and in the ICU 3 hours later. This actually happened to my neighbor when he was about 13, I would say 14. He was out playing basketball and then was in the ICU. About 1 to 2 out of 10 who have Neisseria meningitidis infections die. And even if you don't die, up to 1 out of 5 have some sequelae from it. It's rare, luckily, in the United States, but high in the meningitis belt in Africa, where as many as 1 out of 10 children can be infected. You can see in that map where that meningitis belt is. So this vaccine, there was actually another vaccine, but actually there were 2 vaccines. This vaccine combines the serotypes. There's a lot of serotypes of this bacteria. These are the 5 most common ones to cause meningitis. And so whereas before you needed 2 different vaccines, now you get them all in one, although 2 doses are needed at 0 and 6 months. It can be given to 1 to 25-year-olds in the United States, where we do vaccinate against Neisseria meningitidis before children go off to college, to the military, places with congregate settings. It's recommended at ages 16 to 18, but in Africa, where children are at risk at a much younger age, it's recommended at 9 to 18 months. Again, it's very efficacious against invasive meningitis. We have a new cholera vaccine, another bacterial disease. There were 473,000 cases reported in 2022, and the number was expected to increase a lot in 2023. We don't have those final numbers yet. There are outbreaks in 23 countries right now. Most of the severe outbreaks are in sub-Saharan Africa. The problem is, again, there's been a shortage of vaccines. And so this new vaccine is a simplified formula to produce the vaccine. It's an inactivated bacteria. It's orally, which is good. So it can be produced quickly and given quickly. Oral vaccine, you don't have to worry about clean needles, etc. It has an okay efficacy record, but that's similar to the vaccines we have. So it's no worse than what was out there. And again, the hope is that this vaccine will help reduce deaths from cholera, particularly in sub-Saharan Africa. All right, back to a mosquito-borne vaccine, a virus. Chikungunya is mosquito-borne. There were over 5 million cases in the last 15 years, fever, joint pain, rash. But the problem is symptoms can last for years. The greatest risk is where the mosquito lives, particularly tropical, subtropical areas of Africa, Southeast Asia, parts of the Americas. But again, due to climate change, we're seeing an increase in the areas where chikungunya can be found. And we have seen cases in the United States. This vaccine is attenuated, that is a weakened virus. It's recommended for those over age 18 at increased risk of disease. And age, like so many things, is one of those risk factors. So it's particularly recommended for people who are 65 and older, or particularly if they have an underlying condition. It was just approved by the FDA last November. It's single dose, and this can be recommended for travelers who are going to a part of the world where chikungunya cases are more prevalent. It has a high seropositive response, so most people make antibodies to it for at least 6 months after they get that vaccine. All right, so those are some of the new ones. Let me talk quickly about a vaccine that could be produced quickly. Okay, you may have heard about bird flu. We are seeing cases in cattle. In fact, we've seen cases in over 48 mammalian species, including dairy cattle. We now, just last week, had the 4th human case in a dairy worker, first one in Texas, 2 in Michigan, this latest one in Colorado. And we are seeing in the wastewater H5N1. Luckily, we're not seeing outbreaks yet, but of course, we're concerned. And the CDC maintains these candidate virus vaccines. They have an existing one against flu A, H5N1, that has been shown to provide protection. And so they are working with partners to make tests and large-scale production of this virus should it be necessary. And just last week, was that? Yeah, 7/2 was last week. Moderna was awarded a lot of money to develop a vaccine. But there are concerns that production, should we start to see outbreaks and sustain person-to-person transmission of this virus, it may not happen fast enough. All right, how about some vaccines in development? Well, I hope all of you get your flu vaccine every year. The virus, just like COVID, it's an RNA virus, it changes. And so we need to get a updated vaccine. Their flu, although not as deadly as COVID, still causes a lot of deaths each year. And on the virus, there are spikes, just like COVID. There's what's called the hemagglutinin protein and the neuraminidase protein. If you remember back to bird flu, it was H5N1. That's referring to the type of hemagglutinin and neuraminidase. Those are the important proteins because those are the antibodies you make to protect protect you against infection. You make them against the hemagglutinin and neuraminidase. But as I said, the virus changes every year for different reasons. You can have drift where it changes slightly. You can have shift where it changes a lot, a whole new one, a whole new H or N. And the flu virus, because it has a segmented genome, can infect pigs. Let's say bird virus can infect bird, flu virus can infect pigs, human flu virus can infect pigs. And if the same cell gets infected, it can take some of those segments from the bird and some of those segments from the human. And now you got a potential pandemic on your hand, a whole new virus we haven't seen before. So rather than have to get vaccinated every year, we would love to have a vaccine that would protect against both flu A and flu B and subtypes of the hemagglutinin and the neuraminidase. And just as an aside, the FDA, you may have heard of FluMist, which is a nasal vaccine. There's a lot of reasons why nasal vaccines for respiratory viruses induce better immunity. They're also easier to administer. And for people with needle phobia, which is probably every little kid, easy, not quite so traumatic. The FDA is reviewing an application for self-administration of FluMist. You wouldn't have to go to your healthcare provider. If this is approved, and it could be by this flu season, it would be the first self-administered flu vaccine. Now, FluMist is only licensed for ages 2 to 49. I assume that would be the same for self-administration. So it wouldn't help all of us, but for some. Okay, back to universal flu vaccine. Okay, so as I said, antibodies to the hemagglutinin play a significant role in in your body developing immunity, therefore preventing infection. And so the idea is to look for a part of hemagglutinin different subtypes that is conserved. You can see here, there are some trials going on. I will say that these trials have been going on for quite a while. In fact, this phase 3 trial was, I think it was in 2014. And yet we don't have a universal flu vaccine, do we? The problem was people made antibodies, but they didn't have protection because the immune system is very complicated. And there's another whole arm. If, I'd need another, I don't know, at least 2 minutes for that immunology lesson about T cell immunity. And this vaccine did not induce T cell immunity. But people are still working on that. We are also looking for a combined flu vaccine. That would be great. You could get your, you wouldn't have to get 2 separate vaccines. You could get one. Both Pfizer and Moderna are looking at developing these combination in an mRNA format. And in fact, Baylor College of Medicine here in Houston is one of the sites that this combined COVID flu vaccine will be tested. Pfizer hopes to have theirs available this fall, Moderna next year. And looking at initial results, the Moderna vaccine in older adults, and for a number of reasons, older adults, their immune system, I speak from personal experience, starts to decline like other systems in your body, and you don't respond as well to vaccines. So you don't make antibodies or as much antibody. And so vaccines aren't quite as effective. I am not saying don't get vaccinated. Yes, get vaccinated. It's just that, like many things, it doesn't work quite as well if you're older. So this Moderna combo vaccine had a higher immune response in people, caused this higher immune response against flu than flu vaccine by itself. That's good news. And then Novavax, that protein vaccine, is also doing phase 2 studies on this. So I would hazard a guess that certainly by next year we'll see this. All right, another virus, not respiratory, HIV. It's been around for since the early 1980s. Well, actually earlier, but where we started seeing cases in humans, 1980s. We have been wishing for a vaccine. We've had a lot of different candidates, a lot of disappointing trials. However, we are seeing some maybe potential effective vaccines on the horizon. And this is due to really to improvements or advances, I guess, in how we make vaccines. We now have nanoparticle science using nanoparticles. I'll talk about that in a little bit. To make vaccines, we have mRNA, which has proved to be very effective and immunogenic. We have better adjuvants. An adjuvant is something you can add to a vaccine to make it more immunogenic, so your body makes more antibodies. We have new analyses of the immune response, so we can tell better if the vaccine is working before we put it into clinical trials where we see whether people get infected or not. There was a trial of a CMV vector vaccine for HIV started last September in the US and South Africa. So this will go on for 4 years, and hopefully we'll have some good results. And in this table on the right is just, you can see the effect that HIV has had in the world. Tuberculosis, one of those vaccines, or one of those diseases rather, that also kills a lot of people. It is this in 2022. It was the second deadliest vaccine, only because of COVID, which took the #1 spot. It usually TB is #1 in terms of the one that kills the most people. It's a disease of poverty. And we have had vaccines in development for 20 years. There is a vaccine out there called BCG. It is not used in the United States for some good reasons, and it's not a very good vaccine, but it's all we have. So it is used in other countries. There are a number of vaccines that are in clinical trials. The most promising of them is this M72AS013E. It's a subunit that vaccine. That means it's part of the tuberculosis bacterium. Requires 2 doses in phase 2 trials. So this is with 50 to 100 people looking to see about side effects and also, does it look like the vaccine might work? It had a 50% efficacy in against pulmonary TB for more than 3 years in HIV negative, because HIV is a confounder here, 18 to 50-year-olds who had latent TB. So you can have latent TB for a long time. You don't know you have it. The bacteria is sequestered. It's not causing anything. And then suddenly something happens to your immune system, HIV, older age, other things, and that bacteria bursts out of its sequestration. Your immune system isn't keeping it under control anymore, and you get pulmonary TB. So this is very good. 50%, is really quite good for this. Now, this is an HIV negative, but clinical trials were started in South Africa last March with more people to see how well this potential vaccine works, and it will be expanded to other regions with high levels of HIV and TB. Shigella. Shigella is a nasty bacteria. It causes over 200,000 diarrhea deaths per year in children under the age of 5. Of course, older folks can get it. They just aren't as likely to die. It's the second leading cause of diarrhea mortality. However, among all ages, and like so many things, the greatest burden is in low and middle income countries. There are several vaccines that are at that preclinical or clinical development stage. there is a phase 1 trial that showed this vaccine was safe and strongly immunogenic for at least 3 years. And so it's continuing into another trial in infants in Kenya. I said that the greatest burden is in low and middle income countries, but we also can see it in the United States in crowded conditions, in soldiers in field situations where there may not be good hygiene, and among travelers who go to countries where Shigella is there, and men who have sex with men. So you can see this in high income countries. Another bacteria that causes diarrhea, enterogenic E. coli, ETEC. It causes about over 200 million cases each year. And again, we see deaths in children under the age of 5. Now, this bacteria is very heterogenic, but luckily there are only a small number of the strains of this bacteria that cause most clinical diseases, so that that's what we're targeting in a vaccine. There are a number of candidates early in the process in phase 1 to 2B trials, but there is one that is in phase 3 trials in Africa. It looks to be safe and effective, and so the hope is that we will have this available in just a few years. Whoops. And then the last one I'm going to talk about in somewhat of detail is Nipah virus. Fruit bats are considered the natural host. It can cause these symptoms: fever, headache, dizziness, etc. The case fatality rate, that is, of those who are infected, what percent die, very high, not one you want to get. There was a phase 1, so the first step begun last January. It's vector vaccine. And if this looks good, if it has good results, then the next step will be to do phase 2 trials in a Nipah infected country. So there are other vaccines we wish we had, one against gonorrhea. And I forgot to mention when I talked about Neisseria meningitidis, that bacteria, same genus, Neisseria, as gonorrhea, much different diseases. But those vaccines against Neisseria meningitidis do show some protection against gonorrhea. We wish we had them against some other STIs like syphilis and chlamydia. We wish we had against norovirus. You get on cruise ships, nasty vomiting and diarrhea, very infectious, non-typhoidal, so not typhoid, but salmonella bacteria that causes other diseases, paratyphoid fever, schistosomiasis. It's a parasite that's carried by snails, can cause a lot of problems for your liver. Hepatitis C virus, neglected tropical diseases, NTDs. There are 13 of them that not a problem in the United States, but certainly in low and in some cases middle income countries. Group A and Group B strep, and then mRNA versions of current vaccines we have, because the mRNA easier to produce and seems to elicit a good immune response. We also have some new platforms for vaccine development on the horizon. We have these virus-like particles that, you can guess from the name, it mimics how a virus appears to the immune system, but is manufactured. It's not infectious. It's not alive. And along the same lines, nanoparticles, where you can use the nanoparticle to display the pertinent part of a bacteria or virus to present to the immune system and make antibodies. We have mRNA vaccines. There is work being done in DNA and RNA vaccines that look promising. We also have new vaccine delivery mechanisms. such as extracellular vesicles, EVs. These are squishy balls where the pertinent antigen is inside, and this lipid bilayer, the advantage is that it lasts, so it can last longer in your body, which means your immune system sees it longer and you make more antibodies. Also, in this picture are microarray patches. This has been used in Africa to develop, I'm sorry, I'm saying all the wrong words, to deliver measles and rubella vaccine. Great immunogenicity. The advantage is that there is no cold chain required. And again, the cold chain where the vaccine has to be kept cold every single step of the way is very difficult when you're working in hot climates, particularly in low and middle income countries. It has a lighter weight. The half of the cost of a vaccine is in the last mile of delivery. These are very light. That helps with cost. Anybody can administer. You just stick it on the skin. That helps with administration, and it's painless for people who have needle phobias. You don't need to have sterile needles, et cetera. There was an article published in Lancet last year showing again that using these to administer measles and rubella vaccine worked very, very well. So we may be seeing more of that on the horizon. And lastly, I want to say that vaccines are not enough. It is not vaccines that save lives. It is vaccination, vaccines in arms that save lives. Part of the problem is cost of development. You remember that dengue vaccine that was actually approved, the manufacturers aren't doing it anymore. It's very expensive to develop vaccines. The clinical trials are very expensive. And if it's a vaccine that you only need to get once or twice, unlike medication for high blood pressure that people take for the rest of their life, the pharmaceutical companies may not recuperate their cost. Therefore, vaccines also can be a high cost. There are distribution issues. I talked about the cold chain, for example. We have missed opportunities. Children will go to their pediatrician for a cold, say, and the pediatrician, who has a lot of things they need to do in a very short amount of time, will not ask about vaccines that could be given that having a cold is not a contraindication for example. We know that one of the biggest reasons people get vaccinated or vaccinate their children is healthcare worker recommendation. So if the healthcare worker is not recommending it, vaccination may not happen. And then we've got vaccine hesitancy. Which has been named by WHO as one of the top 10 threats to global health. And there's, that's a talk by itself about vaccine hesitancy, all the reasons. We have needle phobia. I didn't realize my brother had a needle phobia, and he never got vaccinated against flu because of that. And then politics. Yeah, that's probably another hour talk by itself too. I don't think I need to tell you about all the things that are happening with anti-vaccination and politics. So in summary, we have made great advances in developing vaccines. We can prevent some of our most devastating viral, bacterial, and parasitic diseases, but having the vaccine is only the first step, and we need to address barriers to vaccination. Okay, so I think we have 4 minutes for questions, and I can't see it. Let me stop sharing my slides so I can see. Thank you, Guillermo. Questions. Kimra or Courtney, can you see? Oh, I don't see any questions. Certainly, I did not explain everything. There must be some questions out there. Maybe not. All right. Well, thank you all for your attendance. My email is there. If something occurs to you, email me, but not this week. I don't have internet at home. If you have questions or comments. And yes, we are providing a webinar in a few days. It will be sent to you next week, and it will also be on the TEPHI website. And yes, if you have suggestions for September, and I'll throw 2 out there, just if that appeals to anybody. One is dengue, because we are seeing this surge, well, in parts of the country, but also concern in the United States. CDC has issued a health alert about it, or measles, because with declines in vaccination, we are seeing some measles outbreaks. Yes, BCG is better than having nothing, and that is why it is used around the world, where TB is more of a problem in the United States. The reason we don't use it in the United States is because the testing we use to see screen people to see if they have been exposed to TB. You may remember getting some pin pricks in your inner arm, see if it responds. If you've had BCG, you will respond, and we can't tell if it's because you had BCG or because you have TB. And because TB is not as prevalent in the United States as it is in some other countries, that's why we don't use BCG here. All right, I'm not seeing anything else. So again, talk to me, send me suggestions for topics, ask me questions. And I'm going to throw another topic out there. Is an update. I see update on long-lasting flu shot. Yeah, that may not be till next year. But an update on bird flu, who knows what will be happening in 2 months. An update on bird flu and on COVID, what's happening. But it's a little hard to predict what will be happening in 2 months. But if that's a topic that might be of interest, let us know. The role of AI. Maybe I'd have to think about it, because we're supposed to talk about infectious disease topics because of TEPHI's funding. We could do Zika with dengue. Maybe that's an idea. Do some mosquito-borne updates, mosquito-borne diseases. All right. Now I'm not seeing any more. I hope you all have power and air conditioning. Bye-bye.